Assalamu alaikum. Today we will see a joint condition in pediatric disorders, that is juvenile idiopathic arthritis. So this is the condition we are going to see today. Let me open the lecture. See, till now you have seen many conditions related to brain, neurology, bones, orthopedic conditions like scoliosis, dislocations. Then you have seen some pediatric muscular conditions where there is involvement of muscles. Now it is involvement of joints. This is one of the common condition where there will be involvement of the multiple joints in children with juvenile idiopathic arthritis. So it is defined as a chronic arthritis which is happening in childhood. This is causes the swelling of the joints, pain in the joint, and there will be decreased mobility. This is how it is shown, like a regular joint pathology. So this picture, I want to give you some insight of anatomic knowledge about the joint, especially this is a knee joint, where this is the proximal bone, this is the distal bone like tibia. Between two bones there is a space which is filled by synovial fluid, and this area is covered by synovial sheath, and the edges of the two bones will be having cartilages like another thick substances, rubbery kind of substances, but not bones, and it is covered by the capsule of the joint. Then there are some adjacent tendons which will be passing around the joint and the muscles nearby. So all these structures of a joint will be involved in a arthritic condition. So when I'm going to talk more about arthritic condition, I will tell you in detail. So, but currently you have to remember these are some structures around the joint. So now the role of physical therapist in juvenile idiopathic arthritis is to conduct comprehensive examination, to identify impairments relevant to physical therapy intervention, and determine its relationship to activity restrictions. So we should be able to assess the patient and able to determine which of the limitations are restricting the person's participation in the community. This is what we have to recognize. So the juvenile idiopathic arthritis is not a single disease, but a term that encompasses all the forms of arthritis that begin before the age of 16. It is persist for longer than 6 weeks, and what is the cause for this particular disease is unknown. There are no definitive laboratory tests for juvenile idiopathic arthritis. In any of the joint disease, what you get the laboratory findings, similar findings will be there, but there is no specific cause will be detected. That's why it is called idiopathic. You don't know the reason. Juvenile, it is happening in years less than 16 years. Arthritis, it is involving the joints. That's why it is called juvenile idiopathic arthritis. The diagnosis is primarily clinical and undecided until a clear picture of disease is evolved. So if you see this picture again, the picture of a normal joint which is having a good alignment and shape. Whenever the joint capsule is getting destroyed, the cartilage is getting destroyed, the bones will change their normal alignment and they go into abnormal shapes. So when you are doing a physical therapy examination for this kind of disorders, first you have to consider the stage of the disease, whether the disease of the child is acute phase or it is subacute phase or it is chronic phase. Why? Because acute phase, there are great number of impairments. The intervention is affected when child is not adequately medicated. Because whatever therapy you want to do, patient will be having severe pain in the acute stage. That's why they won't be cooperative. And second one is, what is the age of the child? What kind of motor development the child has developed before the onset of the disease? How is the cognitive and emotional development of the child? All these things you have to take into consideration. The participation and activity restriction. The impact of JIA on child's activities depend on extent and duration of active disease. For example, if the disease is a classic example, if the disease is having early impact on motor activities, is the change in ambulation in a toddler with arthritis in the knee leading to change from walking to bottom shuffling. That means a child who is already developed walking, but if the child is having a disease of juvenile idiopathic arthritis affecting the knee joints, the child will be having severe pain in standing and walking. So instead of standing and walking, the child start doing bottom shuffling. That means sitting on the buttocks and trying to move from one place to another place by moving the buttocks. So this kind of changes may happen in the child normal functions based on the disease. The main cardinal signs of inflammation are whenever there is a joint is arthritis, anything ends with itis, A-I-T-I-S, anything ends with itis, that means it has inflammation, arthritis, bursitis, musculitis, capsulitis, periarthritis. Okay, like that, anytime if you see itis at the end of any word, that means the particular structure is getting inflamed. So if it is getting inflamed means usually it will be increase in size, that is swelling. There will be pain, especially stress pain when you want to stress the joint movements. Like for example, this is the joint. If you press like this, there is a pain. And loss of full range of motion. The swelling around a joint may be the result of intra-articular effusion, synovial hypertrophy, soft tissue edema, or periarticular tenosynovitis. I will show you all these things in the picture. But most important is why it is getting inflammation. So why it is getting inflammation is because of the autoimmune response. Sometimes what happens in the body is the body detects some of our own structures as a like bodies which have come from outside, like a virus, like a bacteria, like a poisonous substance, like that. It will detect our own body parts. As soon as our own body part is detected as an enemy, then the body starts fighting with that particular area by using immune system. So whenever the immune system fires in that area, there will be increase in size of the blood vessels. There will be more amount of histamine coming to that area. The more blood will be coming to that area to clean up there will be increased vasodilatation of the blood vessels. So like that, the joint will be become very painful area. So because of this inflammation, which is happening in the synovial fluid, so there will be synovial fluid is getting more blood supply, becomes grown and becomes more thicker in nature. So that is called synovial membrane hypertrophy, synovitis, inflammation of the synovial membrane. Okay, then it will cause musculitis, tendinitis, tenosynovitis. The joint may also be enlarged as a result of bony overgrowth due to increased blood supply to the named area. So whenever area is affected, there will be more blood supply. Automatically, that area will grow in abnormal fashion, especially in children. The swelling and protective muscle spasm contribute to the pain. So whenever it is stretching beyond the capacity, it is going to cause a stretch pain. So if you stretch your skin, you will come to know. The chronic inflammation causes abnormalities in joint structure and function, increased production of synovial fluid, stretches and weakens the joint capsule and adjacent structures, leading to ligament laxity and joint instability. So that means I'll go back to my first picture. See, whenever this is the pink is normal synovial fluid, whenever this normal synovial fluid is becoming inflamed, there will be more synovial fluid. There will be stretch on the synovial sheath. There will be stretch on the ligaments around. There will be stretch on the capsule. There will be inflammation extending to the tendons which are passing through the joint. The muscles also will be inflamed and they will become spasmodic. So this is the initial stage. If this stage is not taken care, after some days the inflammation increases. But since the capsule ligament are weak structures, they are not controlled by our own body. So as soon as they stretched in a as soon as they are stretched like more than their limits, it is called yielding point. If it is stretched more than their yielding point, they cannot come back to their original shape. So when they are not able to coming back to their original shape, what happens is they will become slack or loose. So when the ligaments are loose, the ligaments, capsule, synovial sheath, they are the things which control the static stability of a joint. So whenever static stability of the joint is gone, then automatically the person will have abnormal alignment. Because of the abnormal alignment, there will be abnormal muscle forces happening on these bones, and because of this abnormal muscle forces, they will have abnormalities in the movement, pain, difficulties, etc. So the therapist should be aware of possible patterns of joint restrictions in JIA and their potential effect on function. For example, if they are affecting knee, usually the commonest thing what you observe in the knee is knee contraction. The knee muscles will be contracted and they will be having difficulty in the complete extension, difficulty in the complete flexion, difficulty in the complete extension. Then if they have arthritis, it may occur in any joint, but especially the large joints are affected most often, like hip arthritis occurs in 30 to 50% of the children. Joint examination, first consider the stage of the disease, like as I said you, whether it is acute disease, subacute disease or chronic disease. Each stage of the disease has its typical joint expression. The acute early phase of disease is dominated by joint inflammation, joint effusion. There will be ligament laxity slowly setting in. There will be joint laxity and joint instability. The subacute and chronic stroke phases. Now, the inflammation has become prolonged. If it is there more than 3 months, it will cause leading to joint swelling due to synovial hypertrophy. So it becomes like a Duffy hypertrophy. Loss of joint integrity, the shape of the joint will be gone. Loss of normal joint physiology. There will be erosive changes happens on the cartilage. So the joint will become degenerative. The loss of ligament alignment. During the joint examination, special attention should be paid to those typical disease expressions. The muscular structures, what happens to the muscles around the joint? The different stages of the disease will show a difference in muscle structures and functions. The acute phase of the disease, the periarticular musculature of the affected joint will be having spasm because of the inflammation, and the tone will be high. And it is referred as a contraction deformity. That will be the reflex painful contraction, we call it in the muscle. The subacute and chronic stages of the disease, the muscles is not used for prolonged time, so they become atrophied, they will become weak, and they are pronounced especially near the affected joints. This is also may occur in distant areas and persist long after remission of the arthritis. Contribution factors to the altered muscle structure and function include alteration in the anabolic hormones, production of inflammatory cytokines, and highly resting energy metabolism, abnormal protein metabolism, motor unit inhibition from the pain and swelling, and disuse of the muscles. All this together makes the changes in the muscles. And also, a disease onset very early in life with long periods of active arthritis may negatively affect muscle development. So there are some other symptoms like there will be swelling of the lymph nodes, fever, swelling of the joints, there will be rash around the eye, they have stiffness in the joints, they have clumsiness. So all these symptoms also will happen along with the pain. So the evaluation is usually divided into various components, namely health related fitness and oxygen uptake, performance related fitness and health related fitness. The VO2 max or VO2 peak is most frequently assessed using progressive graded exercise test on a cycle ergometer with respiratory gas analysis in the children with JIA, although some researchers have used treadmill testing in children with JIA. So usually they try to check your oxygen saturation capacity. That means whether you are able to walk for a longer period of the time, not like that, they will be able to assess. A large body of evidence shows that peak oxygen uptake of children and adolescents of the age between 6 to 7 years and 18 years AIA is lower than that in healthy peers. That means as they are increasing their age, the disease will be crop and they will be decreasing their physical activity power. So what this indicates to us? This indicates to us to start a physical fitness program for any child who is diagnosed with the disease as early as possible to maintain the body. Then it includes components like muscle strength, anaerobic capacity evaluation. Impairments in muscle strength include weakness in especially hip, which is in extension, abduction, knee extension, plantar flexion. This will be weak. Shoulder abduction, shoulder flexion, elbow flexion and extension, wrist extension and grip. These muscles will be weak. Muscle bulk, strength and endurance should be examined at disease onset and monitored regularly. So we have to check the muscle endurance, range of motions of major muscles and monitor. So once we have detailed assessment of each muscle, then bilateral measurements of circumference quantify asymmetries in muscle bulk. Functional muscle strength can be estimated in young children by observing their performance or age appropriated motor tasks like ADLs. So along with the performance, we will be assessing the pain also. Pain is one of the cause of activity restriction in JIA and is a predictor of the child adjustment to the disease. Acute pain may result from inflammation and some medical procedures. The cause of chronic pain is less clear, but it may be due to, at least in part, to the abnormal joint loading during activity as a result of soft tissue restrictions and muscle imbalance. So what they are trying to say is, in acute stages there is less amount of pain, but as the pain is going to be increased as the structural damage starts, and the chronic stage the pain will be major due to the weight bearing which is happening on the diseased structures. Older children, especially those with newly diagnosed with GA, report more than the younger children or those with long-standing disease, suggesting that pain perception and report are more closely related to the age than to the disease severity or duration. The assessment of pain, the validated pain behaviors of AIA include the child will be trying to guard that area, will be trying to cover that area, they'll be rubbing that area, they won't move that joint, they'll be flexing always. So all this indicates the joint is having pain. The growth disturbances also can happen. The retardation of the linear growth is associated with extended periods of active disease and is exacerbated by the long-term use of systemic steroids. Accelerated growth may occur during remission of epiphyses are still open. The puppetry appearance of secondary social characteristics may be delayed because of the disease process. So now, as a summary of the disease process, I will talk about the video in the next lecture, about the intervention in the next video. Till now, less than 16 years of the children, if they are affecting with any joint arthritis and you don't know exactly what is the reason for this arthritis of the joint, and it is happening in multiple joints, then you name it as juvenile idiopathic arthritis, which is a group of arthritic condition. So what happens in the joint? The joint will be having an autoimmune response. It will cause inflammation inside the joint. So synovial fluid will be increasing. The synovial sheath will become thick and inflamed. It is called synovitis. And the capsule again will become inflamed because of the increased blood circulation. It's called capsulitis. Then tendinitis, the arthritis of the joint, all these things cause pain, difficulty in range of motion, decreased muscle strength, and decrease their quality of life. So what you have to do as a physicalist? Till now we are talking about assessment. So as a therapist, what we have to do is we should be able to assess all the problems which are faced by the patient, and we'll be trying to protect the joint from further damage. So that will be our physical therapy goal. So up to this is the first part of juvenile idiopathic arthritis, up to the assessment part. Take a break for 5 minutes, then we will join the second part.